This is pharmaphorum Web Editor Nicole Raleigh, and I am on site at ESMO 2024 in sunny Barcelona. And today I have with me experts from EVERSANA, a parent company of pharmaphorum. Today we'll be exploring the 2024 European Society for Medical Oncology conference and looking at key trends and takeaways from that. First of all, please could you introduce yourselves? Let's start with you, Barry.
Yeah, hi, I'm Barry Vucsko, SVP of Strategic Development, and I'm here with a group of true experts because these are the group of people from our Center of Excellence, our Oncology Center of Excellence.
Gurdip Daffu. I am a VP of Medical Strategy with EVERSANA INTOUCH.
Marie Robertson, Executive Vice President. I run the outsourced commercialization for oncology.
Vanitha Sankaran, also a VP of Medical Strategy at EVERSANA INTOUCH.
So one of the things that I saw, I think more than I've seen at ASCO or EHA or ASH over the last few years, is the talk about AI. This has been big news here, and I know this afternoon it's going to continue to be news in the Presidential Symposium 3. But there's been there's a short talk yesterday that talked about AI, but it's also been just chatter on the floor. I mean, you can see that they're talking about it more and more on the floor. Just walking the floor, you hear people talking about it more seriously than they've ever talked about it before. In the short talk yesterday, they talked about practical ways to actually use AI, even in treating patients, and how to come up with treatment plans for patients, which I've never actually heard a lot of talk about before, seriously. And that's the thing that I think is really exciting, because I think the more we talk about that, the more that becomes a reality and the more we get closer to cure.
So purposeful AI, not just jumping on the bandwagon.
Right.
Okay, so what about other sort of unique things we've been hearing at ESMO this year?
Well, I can talk about how the promise of biomarker research is starting to come to fruition. We are starting to see, on the floor in the exhibit hall and in the talks, people talk about diseases as a continuum or a spectrum. It's not just that a patient has a particular disease, they have it with certain biomarkers. And a lot of this biomarker research is fueled by AI and, really digging into patient characteristics and how the presence of a biomarker now can impact the physician's choice of treatment. They can say to their patient, you have this disease, you have these biomarkers, so you're going to respond to treatment A much better than treatment B or C. And that's really exciting because that means our response rates are going to go up and patients are really getting that sense of personalized medicine.
Exactly, bringing in this personalization, the individual, the patient as human individual at the center. Anne-Marie, any insights into the unique trends at ESMO 2024?
One of the trends I've seen is really meaningful multidisciplinary interaction. Like two of the presidential papers I thought were really great in terms of going out and being able to use what we learned immediately. One was in prostate with enzalutamide being combined with radium-223, and one was a really cool cervical cancer trial where radiation, chemotherapy, and pembro were used together, and the trial was recruited all across the world. So I walked out of there thinking like that was learning that everybody in the room could go home and use right away.
Thank you. And we'll come back to this sort of putting at center more women's cancers, actually. That's, for me, personally, that's come to the fore this year. And anything else?
Yes, thank you. So what I've really noticed is all the research and advances that we've seen with circulating tumor DNA or ctDNA. There's been great advances on day one. We heard a talk where they reported that ctDNA will soon be informing staging with solid tumors, and that's something new, and it just shows how far we've come over the last few years even. And just yesterday we heard a really great talk on ctDNA showing that the evidence is accruing where we can show the clearance of ctDNA before and after treatment or even surgery. That may be soon a surrogate for long-term clinical outcomes in patients, and that's a milestone, and that's really just promising.
So if we come back to your thought, Barry, about the AI and its purposeful implementation, and how it could be used in the patient program, as it were, put together by the HCP. Does anyone else have some thoughts that they've heard various things at the conference this year on AI in that regard or in another regard?
I mean, there was a great talk yesterday about AI in terms of not only that what we've been hearing about over the years and the impact it's going to have with pathology and radiology, but also now with medical oncologists and how it may impact their role and their day-to-day functions. I think the jury's still out, though, to see where the chips land with all of these roles. But we're slowly making progress, and we're seeing where it can be most utilized to be of benefit to the healthcare provider, but also for patients. And sometimes it's even just the day-to-day function, right? Like transcribing what's happening in the clinic. That can save hours on a healthcare provider's day. So it's also, these other things that we don't necessarily see research on or presentations on, but I think just that day-to-day function will be interesting.
There were some cool jokes about how you should not put your patient's name into AI because of the data privacy concerns, and some really cool jokes about like whether or not you can ask what the appropriate regimen is and like how to ask that question to actually get viable information versus like vocabulary words that might lead you to information that's less really impactful.
I would also add there that there are a lot of different kinds of AI models, and some of these have been tested and approved for a particular type of setting, with regards to the regulatory rules and whatnot. And there was some statistic about how, a few years ago there were hundreds of these models that were being tested and approved. Now there are thousands. And so it's a little bit of a cautionary tale. Like, we want to make sure that we're using the best of this technology, but like my colleagues have said, we don't want to go awry. We don't want to rely on, the new version of Dr. Google.
No, exactly. I also had something coming back to the women's cancer focus about also avoiding that gender bias in the training of the AI still. And it referenced back to the Amazon debacle a while ago now. So AI very much still has to have the human in the loop and has to have very careful training. And as you say, no names into the system.
And also not just the gender bias, but racial and ethnicity bias.
Yes, exactly. Yeah. So if we switch now to diagnostics.
One thing I noticed was incredible patient engagement in the ALK area of lung cancer, which is a little bit interesting because I saw less patient engagement in areas where you would normally expect it, like breast cancer. But there were multiple talks here that talked about the ROS determinant inside the ALK area, and really like powerful women speakers talking about how advocacy makes a big difference in asking for those tests and understanding what exact type of lung cancer you have.
Yes, bringing this patient voice in for advancement.
Speaking of patient voice through doctors this time is there's a very interesting exhibit out on the floor now asking people to come help design the trials that they want to see. We talk a lot about diversity in trials and enrichment of trials, but here this company has their pipeline there, and they're inviting commentary from all the attendees. What do you want to see in these trials? What demographics are you looking for that you haven't seen before? And that's kind of an interesting take.
And important because we still hear quite a lot broadly how clinical trials aren't yet hitting all those demographics. And there are pockets of medicine that haven't actually looked at particular pockets of society. And it's no longer acceptable and should never have been acceptable. Let's go more generally. So rapid advancements. There have been multiple that have been spoken about, obviously within the field of oncology this year. What do we want to speak about and sort of highlight from the conference?
So yesterday there was a great presentation in the presidential symposium about using a PD-1 inhibitor for anal cancer, and really exciting because these inhibitors have been around for numbers of years now in different oncology indications. Never seen it before in anal cancer, and to have a success with what we might consider an older type of drug. in a new space is just really exciting.
Very exciting, and excitement has been a word as well. So if we think about excitement, we think about rapid advancements and maybe pass the mic along. Anne-Marie, for example, do you want to go back to some of the developments that we've heard about in women's cancers? You mentioned cervical cancer earlier. Are there any other cancers you wanted to highlight progression in?
One of the larger talks yesterday was about whether or not you do both an IO checkpoint inhibitor prior to surgery in triple negative breast cancer as well as post-surgery. And I think everybody watching was really intrigued by the data, but that's certainly an area we're going to have to look and see what happens with like authorization, reimbursement, and does that actually become practice changing?
Yes, and reimbursement with these new advancements also has been talked about at the conference, the practicalities of it, so there is access eventually. Sorry.
Well, in terms of for women's health, I attended a presentation the day before yesterday where the OS data read out for the PARP inhibitors, Zejula and Rubrica, and they were negative. So it was pretty astounding when you have such a positive result with PFS, and that alone is helping so many patients. So it begs the question if OS is the right endpoint in this area. There was great discussion about that following the presentations. But we see patients benefiting from these drugs. So it's disappointing to see that the OS we didn't see the OS benefit.
Absolutely. So Barry, did you want to add anything to the general sort of advancements you've heard about, excitement that's been bubbling up? I have seen quite a few excited scientists, I must admit.
No, but I do want to comment on the conference floor. I think one of the interesting things on the conference floor, and I'll say I haven't been to ESMO in a couple years, but one of the things that I noticed was the medical affairs booths getting far more attention than some of the promotional booths.
Yeah, see,
I mean, medical affairs booths, part of the booths, or even there were whole booths out there that were only medical affairs and not promotional at all, that were getting a lot of buzz and a lot of excitement and a lot of conversation around there. And that's something that, frankly, I've seen at ASCO in the last couple of years too. And you're seeing more and more and more. And I think this is becoming the reason why more people are coming to these conferences, to find out what's in the pipeline and to learn more about what's coming than maybe to interact and do the VR and touch the screens. Now, as the guy from the agency side, EVERSANA INTOUCH, I don't always want to hear that, because of course I want to build these beautiful things for my clients, but I also want to make sure that the drugs they have in the pipeline are the ones that are going to be the next great thing and solve the problems for people who need them.
Yeah, I absolutely want to echo that. What I'm seeing on the floor here is there's a lot of space for people to sit and talk and not just network, but get into the details of what a specific trial is saying or why a particular drug is in the pipeline. That era, I remember, okay, now this is a little pre-COVID, but I remember when we had VR experiences everywhere and we would have these augmented reality or HoloFans or, even at ASCO that were meant to be the bug light, to draw you in and keep you in the booth and interacting. But now what I'm seeing is that these booths are being designed with lots of space to sit and talk. If there is a bug light, it's something that invites conversation, invites people to, look at something and then ask questions. You're also seeing, ways that people can take away information that are more eco-friendly, QR codes that lead to somewhere instead of materials that you have to take away. So the whole feel of the conferences have been changing to something that is more focused on the science and what it can do for us.
There wasn't a single putting green or Lego structure out there.
You asked about women and you asked about the voice of the patient. Several of the booths were designed to make the physician walking by think a little bit about their patient. So the Bristol Myers booth has a whole section where you're essentially entering one of their grandmothers as the patient into her home and like watching this patient be able to take care of her grandson. And then ASI has a part where their patients drew cartoons about what their cancer experience was like so that the physician got to essentially understand what it meant to go through that experience. And then there was another booth that talked about HER2-positive breast cancer in the same vein. So I do think that the many of the manufacturers' booths were representing that voice of the patient.
Right. No, as you say, though it perhaps didn't need to be said, the patient is centric. So that's very much become obvious here at ESMO 2024. For my own part, if I want to add anything, it is this DEI element, and that goes towards the workforce as well, and more women as first authors on papers was one of the talks I personally went to as well. So it affects DEI, not just the trials, not just the patient demographic, but the workforce itself working for better outcomes for those people. Any last thoughts, any key takeaways before we close down this lovely little discussion?
One of the things I was personally interested coming here is how do patients actually get care for ancillary toxicity? Kind of what you're talking about, right? Like, how do you go back to work? How do you take care of your family? And I saw a lot more posters about toxicity management than I had in prior years.
Yes, brilliant. One other thought I've just had, I've heard a lot more about the possibilities of combinations of drugs, and how the words collaboration and partnership are much more accepted, and this idea of de-siloing is the way forward, and being, noted that you cannot be in a silo because it won't be the most effective outcome possibly.
I will just say that I think, we have so much progress being made in all different therapeutic areas. Something that everyone needs to, continue to think about is treatment sequencing. So we have ADCs, we have bispecifics, we have our, monoclonal antibodies, and it's how do these all fit together in any therapeutic area? That's going to be a huge challenge going forward. And do we treat one ADC after another, or is there is it necessary to alternate in terms of sequencing? I think these are all just questions that still loom over everyone, and that's going to be a huge challenge going forward.
Yes, so challenges, innovations, plenty of both, but at the end of the day it's about the science in order to bring better outcomes to patients. And that passion is very much evident at ESMO 2024. I think we all agree. Okay, well, that's it. Thank you very much for your time. It's been a pleasure.
Thank you, Nicole.
It's hers.